Thank you so much to both Adrian and Abigail for your stories. Adrian's is an excerpt from a larger podcast where I had the honor and privilege to interview her. The link will be in the chat. One of my colleagues will be able to share that, a part of a longer episode titled Dying to Be Heard. And also, Adrian is in the chat. So thank you, Adrian, for your stories. Thank you, Abigail, for the work that you do. And when I hear these, not just stories, but lived experiences, what I think about is the importance of building a healthcare team that honors and respects you and your customs and your culture and the knowledge that you bring into the room. So I am so happy to be joined by an amazing panel today where we get to talk about what it truly looks like to build that type of healthcare workforce team. But also not just limiting it to the relationship between a patient and a provider, because that's what some of us initially think about, but also a robust team, a holistic team. So thinking about home health aides, thinking about community healthcare workers, thinking about caregivers, policymakers, we all have a role in making a difference. But since we do immediately think about the relationship between a patient and a provider, I would like to start with Robert Rock with a little introduction. You are a doctor, but that is not why you are on this panel. You are on this panel because you get the honor and privilege to be a part of a health justice fellowship program. So tell us a little bit about the mission of that program and how it equips our providers to serve our most vulnerable populations.
Thank you so much, Ashley. So I am honored to be the director of the Social Mission Alliance's Health Justice Fellowship, which really believes that students with a commitment to serve and advocate for just treatment for vulnerable populations are already here in the pathway doing the work. But the health professional training apparatus, the structure, really suppresses these values, often socializing those students into silence and giving up on the commitments that brought them to healthcare in the first place. So the fellowship is a 9-month-long virtual fellowship for health professional students who demonstrate a commitment to health justice and advancing social mission in health professions education. We want to support them in staying true to those values that they came into training with and really make sure that they embody them upon graduation. So in practice, the program welcomes students from medicine programs, dental, nursing, physician associate, and public health programs, and supports them with one-on-one career coaching, skill development, and organizing, and op-ed writing, research opportunities through the Social Mission Alliance and the greater GW network that we're connected with, or George Washington University, and networking support to help them in successfully transitioning through to the next stage of their career, whether it be residency training or like going into practice. So as the ground moves under our feet, it's going to be like increasingly harder and harder for students committed to these communities to gain entry and successfully navigate their health professional training. And so the goal of the Social Mission Alliance and the Health Justice Fellowship specifically is to support those students in order to create a dynamic community of health professionals who represent the values, perspectives, and wisdom of those most affected by systems of oppression in the society, those who have been historically barred from the academy and the health professions in the first place.
I love that you talked about values. We'll get to dive into that deeper a little bit later. But now I want to transition to Greg. You work with community health workers, which is a role that people tuning in might have heard of, but maybe they don't actually know the importance behind community health workers, and the special characteristics and how they truly help patients. So tell us a little bit more.
So community health workers, that's an umbrella term. There are many other terms that are utilized. So community health workers, we have community health representatives who are from the indigenous population. And then we have promotores de salud that are from our Spanish-speaking community health worker population. So you might hear CHW, CHR, or promotor. And we are frontline health workers. We're trusted in our communities. They have come to us, have asked for help, have asked for things, and any way we can figure out a way to link them to whatever they're asking for, we find a way. We have been through so many different things in our own lives that on one hand, possibly someone has helped us. Someone in the midst of our troubles and our traumas in healthcare and just in life needs, someone has said, "Hey, let me help you with that." And that person is that guiding light. That person has said, "Wow, I want to help others like you have helped me." On the other hand, we may have gone through things and had absolutely no help, and no one there to help us, no one there to guide us, no one there to give us a resource, just the information, right? And it's not about giving a handout. It's about providing resources that exist. So essentially, our lived experience is what our driving force. That's the motivation behind community health workers. That's what pushes us and keeps us going, no matter what. We build bridges to the resources that exist. So there are resources that are out there that are put out there by different systems, and they try it for a while and say, "Hey, we put this resource out, but no one came to collect it, so no one wants it. Must not be a need." But community health workers are finding out about it. We get people to that resources, and then next thing you know, that resource isn't there anymore because there wasn't this fast automatic uptake of said resource. But we find those resources, we build those bridges, we close those gaps to access of care. If getting a ride is an issue, we figure out, how do we get you to an appointment? How do we get you to getting your medication? If you have medication that you aren't able to pay for or take care of, we find a way and we find a resource to make sure that you're able to get that. We help our participants reach their health goals, and we typically call them participants because we want them to participate in their healthcare plan. And sometimes it's how we help providers understand why someone may not be following a guideline or a rule or a plan that was created without the involvement and engagement of that of their patient, of our participant. So we connect the dots, and we pretty much find a way to make no way, or we find a way out of no way to make a way. That's what we do as community health workers.
Well, if you don't have that on a shirt or a mug, I would say y'all heard it here first. Okay. So, Greg, that's an idea that you need to get some branding on top for all of your community health workers. Put it on a pin. There are multiple ways that that could go. And Ilana, you get to bring a unique perspective to this conversation because your work is rooted in organizing. So, share with us, what are some actual practical examples of what organizing is and what populations do you serve?
Hi, everybody. It's so nice to be here. And I love that, Greg. I just want to say one of the places where I sort of learned organizing, and some of my first organizing friends were out of this organization in the Bay Area called the Center for Third World Organizing. And their motto was, "If we can't find a way, we'll make one." So very in line with that. But so Caring Majority Rising is an organization made up of older and disabled New Yorkers. We're in New York. It's a state-based organization. So older and disabled New Yorkers, home care workers, and family caregivers. And Ashley, I promise I will answer your question. But we were looking in terms of healthcare equity and workforce, home care, and the fact that our population in New York and around the country is aging very rapidly. People are living longer. That's great. We can have vibrant intergenerational communities. Most of us, the vast majority of us, would prefer to live and age in our own homes and communities, remain active in our communities, and not end up in a nursing home. And the reality is, for many of us, home care is what makes that possible. And the challenge is that, one, home care is not affordable or accessible for everyone. And two, even if it was, the workforce is criminally underpaid. It is hard work, it is emotional, physical hard work, and it's very underpaid. And so where organizing comes in is, we looked at the future of, and we already had in New York a huge worker shortage. We had people sleeping in their wheelchairs, unable to eat, unable to, take out the trash because they could not, even if they were eligible for home care, there were not workers available. And we said, well, what we need to do here in New York is basically find billions of dollars of investment, both to pay workers well and to ensure everyone who needs home care can get it. Well, that's not something that's going to happen magically. It's a huge fight to get resources for communities that all have been underfunded and left out. You have older and disabled folks, home care workers, which is a workforce that is largely women of color and immigrant women. So the only way to get that is to fight to take what we need. And so we built a coalition of all of the impacted stakeholders and, did multi-year campaigns to really educate the public, have folks who are directly impacted share their stories and also their knowledge that investment in home care is a good investment for all of our communities. It's a good health equity investment. It's a good economic investment. And we built a campaign, Fair Pay for Home Care, that ultimately won $3 an hour raises for home care workers across New York State. It was a $4 to $7 billion investment. But I think I'll just close by saying, with all of the really hard topics that are being addressed here around equity, we're living in a time where all of the organizations that do such good work supporting people are having to do more and more with less as the government keeps cutting. And so while advocacy and service and all these things are important, we also need to organize and really bring people together and fight, honestly, for resources that are deserved and, to really to build equity across the spectrum in our country.
Thank you. And I see that there is some overlap between all of you all's work, especially you, Ilana and Greg, with the populations that you serve. So what I would like for you to share, Greg, is what impact are you seeing on the patients that you serve? I know Ilana mentioned a little bit what she's seeing in her world with all that is changing rapidly in our landscape. So what is the impact that you're seeing?
So some of the folks that I serve directly, they are not able to get care. They are not able to get the things that they need. When we're talking about the community health workers that I train here at the community Center for Community Health Alignment, which is in South Carolina. South Carolina, we're one of the last states holding on that have not expanded Medicaid. And so while different things are happening, we're not even able to utilize resources that exist because of what's happening with our state specifically in that way. But if you don't have the funding for a project, or when something is getting cut because it says equity, because it says inclusion, diversity, those things, then that funding gets cut, then you aren't able to have community health workers still on your team if you've hired them only based off of a grant. I can talk about that more in a bit. But if we don't have the community health workers on our teams, then we don't have the community health workers to be the bridge builders. And if they're not on a team, they're not building bridges, and they don't have jobs, now the folks that are helping need the help, need the assistance. It's one thing to advocate for others. And so many of us as community health workers do that. We advocate for others time and time and time again. There's something about when you have to do it for yourself, it's a little bit more difficult. So we often tell community health workers, like, hey, have a buddy system so you can have a community health worker who is your advocate for you. And so what this does, when the helper now needs the help, when the person providing resources now needs the resources, it keeps the system doing what the system was built to do. And it keeps that cycle happening. It takes the system beyond its capacity because so many people need help, need resources, and it just continues. So it's a cycle that doesn't stop, yet it's the system that is functioning the way it was built to function.
Someone is in the chat saying preach when the helper needs help. Oh, that gave me chills. And Robert, I want to hear from you. What impact are you seeing now on medical school acceptances, programs, the demographics? Because if we're talking about the helper needing help, we need to also go back up towards the funnel of the providers now and how are they being impacted? We know that when your provider can relate and understand where you're coming from, we see greater outcomes. So what are you seeing? And based on the numbers and trends that you are seeing, what type of workforce do you anticipate us seeing 5 to 10 years from now because of what's happening today?
Thank you for that. It's honestly bleak. And I want to start with the statement that even before, Supreme Court decisions in terms of affirmative action and before this current administration came to power, we were way behind relative to realizing a healthcare workforce that looks like the country that it's supposed to serve. And so that means, we are, decades away from making it so that a clinician, whether a nurse practitioner or a dentist or a physician or a PA, can see family in the face of their patients and love them and love on them and support them and advocate for them the way that we all deserve to be cared for. Now, I think with, the SCOTUS decision in 2023 and, anti-DEI executive orders, the uncertainty of it all is really taking its toll. Like materially, students are unsure of how they'll be able to cover the cost of training or pay off the loans that they already have. Educators are really walking on eggshells relative to how they can recruit students or what they can and can't teach in the classrooms without being the risk of being doxxed or retaliated against. The ambiguity around recruitment and support strategies doesn't help prospective students either, because you know, they're doing this for the first time. And so if they don't know that something exists in terms of a resource or a potential leg up, they're not going to ask for it. And it takes a lot of courage to stand in your vulnerability and ask for help. And I think it is creating even more obstacles than there need to be for people who have to overcome so much to realize their dreams of becoming health professionals. The statistics are already out there. I'm happy to share these resources after, but there was a recent paper published last year by Nitian Nguyen looking at um, the application rates and matriculation rates for U.S. medical schools in the 5 years before 2023 when the SCOTUS decision was made and the year after. And it's already showing there is a decrease in the acceptance rate for people who are historically underrepresented in medicine. So think Black, Latinx, and Indigenous. And so, that's 1 year of data. You project that out, it's not going to get better, particularly as, SCOTUS was 2023. Things have happened since then that are making it even harder for institutions to create equity or some level of parity relative to the demographics of our workforce in our country. And so it just makes it really, really challenging. And I think that this is super important for patients because multiple studies show that people from underrepresented backgrounds are the ones who are most likely to take care of people on Medicaid, both in rural settings and in urban underserved settings. And so there are other studies that I can share that show, I'm a family physician, so that's what I'm most familiar with. But looking at the Medicaid claims data for family physicians, I think it was in I'll have to get back to you on the exact date, but I'll happy to share the paper. It looked at Medicaid claims data for over like 50,000 family physicians, and it showed that Black and Latinx community family physicians were that much more likely than their white and Asian counterparts to accept people who take Medicaid. And then for those people who do take Medicaid, for those Medicaid beneficiaries to be very diverse. And so when you think about the way that this is going to trickle down into the healthcare environment that people are going to have to really depend on to get healthy, stay out of the hospital, it's very, very bleak.
Thank you, Robert, and we will be glad to share the data and the different reports that you were mentioning. And Ilana, I know you talked about living longer and the desire to age in place, not only comfortably, but with the care that you deserve. So hearing what Robert just said and knowing the work that you are already, engrossed in, what are some initiatives or solutions that your organization or fellow organizations that you see are really rising up to help fill in those gaps?
Yeah, I mean, I appreciate the sort of continuum of strategies and ideas on this panel. Like, I think that there's many things that need to happen. What we focus on is really, like I said, ensuring that we have a workforce that can. Home care workforce is it is the fastest growing workforce in the country, and it is it's just, we don't have enough people doing the work, again, because it's hard, because it's underpaid. So one, ensuring that that is a quality job, that you can sustain your own family by doing the absolutely very essential and important work of caring for your own or somebody else's loved ones to allow them to remain in their own community. It is, we did a report that showed if you paid a living wage to home care workers, it actually had huge ripple effects across the economy in terms of putting more money out into lower income communities that then create more jobs and allow people to stay in home care. But I think what a lot of this, like the sort of bottom line on all this is, again, and everyone has talked about Medicaid here, Medicaid is a program that is deeply essential for health equity and for the health of so many communities. And so continuing to push our, just go hear me? I'm afraid I'm there. Can you all hear me? Okay, sorry. I think I might be having internet issues.
It was the haters.
Just essentially,
the haters
like,
didn't want you to talk about the importance of
it's the
Medicaid. So
haters.
start
Well,
from the
because this
top.
is what I'm about to say. The haters do not like what I'm about to say. I mean, we have enough wealth in the society to provide every single person in this country with quality health care, quality jobs. And so when we talk about budgeting at a state level, at a municipal level, at a federal level, it's partly a math thing, it's partly a values thing. And so part of our work as organizing is to, and particularly when you talk about the issue of care, this is a very universal issue. All of us at some point in our lives will give or receive care or both. So I think fundamentally for us, the work of organizing is bringing people together across difference, because we all do care about care, to pressure our elected officials to use the values of care in how we create budgets and how we invest in communities across the country. And so, there's many initiatives we're working on in New York, in particular related to deprivatization. So we've been looking at all the different ways that private health insurance companies, private equity companies are taking our Medicaid dollars for profit when we're already in a climate of shortage and scarcity, and we're worried about losing Medicaid dollars to watch our government hand that money off to for corporations is one major issue. And so our campaigns in New York are really related to sort of ensuring that the Medicaid dollars we do have are a public good and are not allowed to leave the system for private profit. Specific details, I'll leave it there, and if I can share.
Yes, and we can also send out more of those resources and different things that you're mentioning in our follow-ups as well. But I love the fact that you all have brought up in one way or another the word values, right? And I don't know if a large representation of people think about values when they think about healthcare and they think about that journey. So Greg, I would love for you to dive into that, because you said earlier, the system keeps on doing what the system was built to do. So therefore, that tells me that the system doesn't value the same things that we all on this call value and the people in the chat value. So I would love for you to dive more into that.
Absolutely. When we think about, you'll hear people say, oh, we need to fix the system, or we need to do, all that. I am big on, no, understand the system, dismantle the system, and build something better. We can't dismantle it all at one time. We have to understand it, because if you don't understand it, to take it down and put it back the same way, because you didn't understand it the first time. So we have to have some understanding about it, right? And when we think about how what things we can do in terms of being proactive and setting certain things in place to help with foundational infrastructure pieces in creating a new and a better system. Understanding that if you help the least of those that you're working to help, you will help everyone, right? Like if your organization has, let's just say you see 30 clients and there are 10 that are consistently late or have some type of issues getting to their appointments, then figure out what's going on with those 10 folks. And your organization may end up increasing clientele because you found a way to get people actually to your location. The best way to do that, of course, I'm going to say is hire community health workers. Community health workers can figure out what's going on. And community health workers are not your typical workforce. So you have to understand we are a different workforce. So you can set a community health worker up in an office and say, okay, when someone comes in, we'll do a social determinant screening and we'll do these things and we'll let them go see the CHW. You're still not meeting them where they are. You are still requiring them to come to you. The system wants us to have folks come into those industrialized systems, as was mentioned before, right? So do something different to get different results. CHWs are boots on the ground employees. We thrive in being in community. We can go, we talk to community, see what's needed, see what's happening. That's not the only place we thrive. Our core competencies include research and evaluation. That is something that we teach in our trainings. We facilitate those conversations in our training. We talk about how to create surveys. What are you looking for in a survey? We create surveys and pass them around and have people take them. And usually I'll be very cynical in my responses because I want folks to understand if your question isn't clear, are you going to get the answer you want? So we teach that. The research and evaluation, we have another core competency for community health workers is education and facilitation so that they can educate those that they are speaking to. If there's a family of 4, but only one person is my direct participant, and I do a home visit, more than likely I'm now speaking to the full family, right? So understanding that community health workers, not just the boots on the ground, not just doing the work in community, bring them to the boardroom, bring them into that C-suite, CEO, COO, all of that. Bring them into the C-suite, bring them to the table, and not simply based on a grant you receive that has what they're looking for in their request for proposals is community health workers, community engagement. Bring them to the table before you ever put that request together so they also have buy-in. So it's sustainability, it's bringing them to the table, it's helping them to understand and helping your organization to understand the needs, and it's putting everything together. Bring them to the table at the beginning, elevate, hire them, offer those job opportunities for them to advance, to increase their professional development, send them to conferences, send them to organizations, get them memberships into various organizations that can help them learn what's happening as they hear the things that are spoken about on a certain level, and then bring it back into the communities and populations that they serve. And so when we're talking about populations people serve, sometimes it's a focus on generational differences. Sometimes it's a focus on chronic health or chronic disease management. Sometimes it's a focus on our recently what do we call it, reentry programs, right? So folks who are incarcerated before they are let out of prison, before they are let out of the system, how can we set them up for success for their healthcare needs before they go back in, so they don't go back into those systems? So they don't come out thinking, oh, I have to do all these things. We get them lined up before. There was someone in one of our trainings who did a lot of work with folks in their reentry program. And they said someone lied on their resume and someone said, oh, I don't, I have not been, they said no to all the, have you been, found guilty, locked up, anything like that. They said no. They did the research and they found that, they did a background check and found that they had been. And she said, I hired them. I hired them. They lied because they understand how the system works. But I need them to understand how the system works so that they can work with this population, so they can work with this community. They get it. I hire them. She then said, I don't hire anyone if they don't have a rap sheet. So again, when we're talking about thinking outside the box, we're talking about how do we make a difference and how do we do something different? Trust the people who have the lived experience. Trust what they're saying. Listen to what they're saying and have them invited, engaged, and at the table from the beginning, and not when you've got a year left of your grant, you haven't met your deliverables, and now there's a panic, and you call in Greg saying, hey, we got to get people trained because you said you'd do it, but you didn't actually plan for it. You didn't actually bring the people to the table at the beginning so that it could be thoughtful and done in a way that works for everybody.
I love that. Once again, that focus on lived experiences. If you have a rap sheet, you know how to work and connect with others. Abigail mentioned that during her keynote, living through sexual violence. So when someone in her community experiences that, there's a heart posture that can't be replicated by someone who hasn't lived that experience. So I love that. And just looking through some of the questions in the chat, Robert, someone mentioned when you were speaking earlier, what are some solutions for this? You started your original answer with things are bleak. So as we wrap up soon, we want to talk about some solutions and some hope. What are some things that you're seeing?
Oh yeah. Sorry for being negative. I tend that way
It's the
sometimes.
reality. It's not about being negative,
Yeah.
you know? It's the
Okay.
reality, and then we bring it back.
So the silver linings. I would say that relative to, banning affirmative action, there are states who have that was their reality before this. And there are institutions within those states, like health professional training programs, that have diversified their admitted students, their current students, and their graduating students in ways that compete with schools in states that didn't have to deal with an anti like a affirmative action ban. And so there are best practices, and the work of the Social Mission Alliance is bringing these people together through our research, through our program evaluation, through our conferences to share those best practices and make sure that no one needs to reinvent the wheel unnecessarily. That these lines of communication and trust are there, particularly in this moment when people want to kind of like be under the radar and don't know if they can trust someone, cold calling them. I think relational work, community organizing are going to be the ways that we like move forward and not lose ground in this moment. And the Social Mission Alliance has like entire resource repositories around how to build better curricula, how to, outreach and engage students, how to different health professional training programs that put community members on the interview panels so that they are really selecting for students who carry those values that they know that they're going to want their loved ones to be cared for by. So there are a lot of really positive examples and silver linings. I think it's going to be a matter of, the resources to implement them in different places, but I don't think we're going to need to whole stock reinvent the wheel in this moment.
And Alana, you talked about the importance of fighting. And I think in the times that we are in now, we all need to find our inner fight, whether we're being directly impacted by something right now or if we'll be directly impacted decades from now. Like you said, we will all be in a position, hopefully, we all live long enough to be in a position where we will, need care or be able to provide care for a loved one. So honing in on that fight, who are some people or some players or some efforts that we can learn from and maybe join and be a part of that will help progress that fight?
I mean, I think there's a lot of great work happening all over the country. I think both Greg and Robert are talking about amazing work, so I want to shout that out. I think there's a ton of coalitions around the country trying to defend Medicaid. I don't know what the like sort of partisan politics are in this, so I don't want to mess up, but I do think there's big national groups like Indivisible that are working around Medicaid fights, and people can look in their local, sort of find their organizations in their own states who are organizing. Um, and I think the really beautiful, and I can share links that you're going to send out later to some good organizations doing this work. I want to say though, the thing that is in a very polarizing, hard time, this issue is very inspiring because it does bring together unlikely partners. And so everything we've worked on in New York has had bipartisan support. We have people in our membership who are from tiny towns, huge New York City, suburban areas, is actually a really good sort of antidote to the polarization and divisiveness in this country, is to work with your neighbors, your communities, your faith institution, your workplace, um, and talk about care and sort of find the commonality in the issue. But yeah, again, I'm happy to share specific links of organizations and our work at Caring Majority Rising. But I think it is on the to not leave on a sad note, although there's a lot of stuff to be sad about right now. I do think this issue is one that really connects us as humans. And I've done a lot of door knocking related to this issue, and it's amazing how people will open their door and engage in very deep conversations and share sort of really intimate parts about what's going on in their lives, because this issue is so resonant for so many people, talking about care, talking about home care, talking about healthcare.
Yes, and a question that Katie asks is, how would you suggest we talk about this with our fellow coworkers and patients without getting into a political argument? But I feel like, Ilana, you kind of just mentioned that it's a human issue. Like, we are all humans. So any specifics that you would like to share with Katie, Ilana?
Well, one, I mean, I do think the notion, I think saying whether it's political or not is kind of a hard, like everything is political, right? In this era. So you don't have to talk Democrats, Republicans ever. I do think it's true. I mean, I think it's true, but we know objectively that there are resources in this country to provide for everybody. And so I think that is a conversation we can have about how could we do things a little bit differently. But I think, yeah, at the end of the day, it is about the issues of care, how we care for our loved ones, feel like they're ours. We talk about them at our kitchen tables, we talk about in our living rooms, they feel like our personal flaws. We are failing if we can't provide for our loved ones. And what I think is the most important part of these conversations is making it a collective experience. All of us have these problems because we have huge gaps in our care infrastructure in this country. And if we can take these problems that we each deal with in our own homes into the public realm, or even just with our colleagues, and be like, wait, this isn't my personal problem, this is a societal problem, and therefore we need societal solutions. I think that's a place to start.
I love that. And Abigail also mentioned that during her keynote, when she talked about the woman that they were caring about. She said, "We all see this woman as our grandmother." And so it's more than blood relation. And if a person is, biologically related to you, it's that human connection. And so, Robert, I'll go to you to share some final parting thoughts.
Yeah, so this is something that I think about and the folks in the Social Mission Alliance think about a lot. And we've created this For Us All campaign as really an advocacy tool to really push the narrative around what does this all mean? Whether you demonize it as critical race theory or DEI or anti-DEI, what are the material benefits of these programs to patients, to communities, to learners, to educators? As a way to really break through that siloing and that is dividing a lot of us. And so we have this campaign as a way to demonstrate tangible examples of this work and the benefits it's having for these different groups across the country, as a way to inspire folks to understand that all is not lost and that it's not about reinventing the wheel. It's about demanding of your governments, your institutions, big P policy, little p policy, that better exists, and that should be the standard for everyone, because no one's free until everyone's free.
Yep. And Greg, your final parting thoughts?
Yeah, I really just want to say, thank you for allowing me to be here. And for those who want to, support and figure out different ways to help champion some of the work that's happening, the American Public Health Association has a community health worker section. And that section connects all of us across this nation and those who are doing this similar work outside of the US. And so that's a great opportunity there to really connect with our workforce and learn about the work that we're doing all over.
Perfect. Well, thank you all for being a part of this conversation. And I'm excited to see where we're all able to join arms and have some impact, so that we don't have these same conversations over and over, but we can sit back and reflect on the change and the impact and the progress that has been made. In spite of all of the attacks, clearly we are all on the same page about driving this forward.